Washington State University. Go Cougs!
So I'm Shelly, and I work with, this is a presentation that was actually developed for a conference that I presented at this summer. So I work with Dr. Cook as well as Dr. Schmitter-Edgecombe. And like Maureen said, I have about 25 years of clinical practice under my belt, and that's what I bring to this setting where I'm qualitatively analyzing quantitative data. That's kind of a cool area to be in, I think, because I like to tell my nursing colleagues, yeah, the engineers are developing these artificial intelligence algorithms that hopefully will be able to extend our reach, help us triage our patients, because there are more older adults, or even outside of that population, there are more patients than there are nurses to take care of them. So one of our big issues is, who do we see first? How do we decide? What I bring to the table is lots of years of autonomous assessment of patients who have health issues, ongoing health issues, chronic conditions, as well as emergent health issues. And so I think about that kind of thing. I want to begin by acknowledging the National Institutes of Health and Washington State University, as well as two private foundations, Touchmark and Lindblad, who both support, all four of them support my research. I want to situate my research in a practice model. So nursing is an evidence-based practice field or discipline. And so we base a lot of what we do with patient care and treatments and following through on what a physician or a PA or an NP has ordered. If we need to draw blood from a central line, there are certain ways of doing that, and we have a lot of evidence from research based around whether we should, for example, pull out 10 cc's, do you guys talk in cc's, milliliters? Same thing. There's a new jargon for you for the day. If you pull out 10 cc's of blood and toss that, and then pull out the next 10 cc's, you're going to get a better look at what is in the body. Some people say that should be 6. Some people say it should be 3. Well, what does the evidence say? So we do research around that kind of thing, and we make our decisions of how we're going to practice based on that. So my research is founded in that philosophy, which is, if we're going to deploy technology to older adults, to my patients, what is that going to look like to them? And so I base what I do in practice in either home health nursing or public health nursing, the philosophies around that area of the discipline. I kind of got into it because I was one of those nurses who was constantly questioning why we do what we do. And I think they got tired of me. So I just sort of floated to the top, because you know that's what happens when people ask questions, they just float up. And that's not always necessarily a good thing, but that's how I ended up coming back for my PhD, because I really wanted to understand how technology would impact patient outcomes and how nurses using that technology will impact patient outcomes. Because I like to say that y'all, if you're engineers and computer scientists, you design really cool stuff that you ask me to deploy on the patient at the bedside while I'm trying to save their life, or I'm trying to help them with their chronic condition. And so oftentimes it's a square peg that I'm trying to fit in a round hole. And so I think being a nurse involved in the conversation for me is very exciting. So once we do the research, we bring it back into evidence that we deploy back into practice. So that's our model. This is probably very basic for you, but is not basic for people who are clinical like me. So I left it in here because this is like, duh. A smart home is made of hardware and software. But you would be surprised at how many nurses or clinicians, speech and language therapists, physical therapists, anybody who works clinically at the bedside doesn't really necessarily understand that there are different components of hardware and what the language is around that, and that there's different components of software and what the language is around that, and what is the role of each piece of this. So I left this in here. You guys are aware, I'm sure, of the smart home, so I'm not going to go into all of the items. Like if I was speaking to nurses, I would have to explain what most of those are, probably. So my work is around the smart home, and this is just a picture of the test bed. Have you guys all been in the test bed? Okay, so that's not news to you. This is this is sort of our model or figure for infusing clinical knowledge into the smart home, and ultimately the interventions that it will take, but up front, how it will detect something that is clinically relevant. Because there's lots of things that you could detect, but if it's not really clinically relevant and it's not going to help the nurse at the bedside or the clinician in any field working at the bedside, it might be useful to you, but it's not useful to us. So what we do here with this research is we deploy the smart home, and through that we can detect activities and behavior patterns. And activity learning can begin to understand what that is. And what the clinician does, so that would be me and my team of nurses, we can look at the data pre-labeling and post-labeling. So what this lecture is going to be about today is how I look at that pre-labeling and what I see in the data and what I'm pulling out of it that I believe is clinically relevant based on my experience. We provide that information to the engineering team, and from there, interventions can be planned and ultimately deployed, and then through the sensor monitoring, we can pick up whether the intervention had a positive impact or didn't have any impact at all, because clinically, when you do a treatment plan and you deploy a treatment plan with a patient, you have to evaluate whether that's working or not. So unfortunately, you probably all have the experience that you've gone to a doctor, here's your antibiotic, and you never see them again. But in reality, what we should really be following up on is, are you taking that antibiotic? Is it helping your symptoms? And in what period of time is it helping your symptoms? Because there are expected specificities around when you should be feeling better with different bacteria or viruses at day 2, 3, 4, 5, 6, 7, okay? But we haven't followed up on that. And now one of the problems that we have is we have a big antibiotic crisis where we have superbugs that are developing because people aren't completing their doses, or they were given the wrong prescription for the wrong bacteria, okay? Or they're getting antibiotics for a virus, and that doesn't work because antibiotics don't treat viruses. So if you have a cold, upper respiratory infection, you don't have a high fever, don't go to your doctor for antibiotics, because pretty much anymore you're not going to get them. Okay, so that's our figure for clinician in the loop. So there are 5 steps that I take when I am analyzing raw sensor data. So those lines and lines of data that are date and time stamped with the sensor labeled. So the 5 things that I do to detect changes in health states as a nurse would. So we might call that changing health status. We might call that somebody who has diabetes now having an episode of low blood sugar. That's a change in health state, okay? The first thing that I do is I organize the health information. Then and that is basically collecting the medical records, reading and understanding the medical record, and interviewing the patient or participant. Okay, so I've been saying patient for 25 years. So when the P comes out, sometimes it's not participant, but in this setting it really should be. And then I identify measures in the literature. I'll talk a little bit more about that. I basically go out in the literature and see what other research teams have done, or this research team here in the CASAS lab, regarding what sensors can pick up what movement and what diagnoses are they relating that to, okay? How are they saying that they can measure and understand what a sensor is picking up? And then I identify a clinical change in health state, either by looking at the raw data and saying, this pattern is odd for this participant. Because I know the participant well, or they tell me that something happened. When I call them on Monday morning, they say, yeah, Friday night I fell. Okay, so I identify the clinical change in health state, and then I verify the reliability of the data. I would like to make sure that if we're gonna feed information to a machine to learn about a change in health state, that we didn't feed a dog moving around the house, that it actually is a change in health state, that there wasn't noisy data because of waves over the internet or battery battery's going bad, and so we're feeding bad data to the machine. I don't want to be responsible for that, so I like to check on that. And then I conduct a scoped review of the data. So clinical relevance, these are some of the things that we consider as clinicians important information, okay? So what is the patient's chief complaint, or what is their mechanism of injury? So take a fall in an older adult. What is their chief complaint? Well, it might be a fall, but it might also now be that, my shoulder is hurting really bad, or my right leg is sore and I can't walk very well, or I seem off balance since I fell. What is their chief complaint? What is their chief concern after falling? And then what was the mechanism of injury? So that means, did they fall from a standing position onto a tile floor? Did they slide off their bed onto carpet? Okay, there's a difference in what can happen to the human body based on that mechanism of injury. That's important for us to know. And I think about those things when I look at the data. Their diagnosis is important because ultimately we want to be able to design interventions for different conditions. So we want to do personalized health care. You guys have probably heard in the news about precision health care. I think that or precision medicine, I think that this smart home and interventions around chronic conditions definitely falls into that. I think there's two main areas in the future of precision medicine. One is genetics. The study of genetics is by far a huge part of that, and it was the beginning of that idea of precision medicine, meaning that we're no longer going to prescribe treatments, including pharmaceuticals, based on the population. You're a young white female, or you're a middle-aged black male, or we prescribe right now across those kinds of populations. But in the future, we're going to prescribe based on your genetics, and I also believe we're going to prescribe based on your big data. So I don't know if you guys have heard of Dr. Eric Topol. He's sort of America's tech doctor. And he calls it womb to tomb data, that there'll be about a terabyte of data on you, probably more for the younger people who are in the room. Womb to tomb data on you, and that will be personalized. You can run algorithms on that, you can retrieve health information based on that, and we can prescribe treatment plans based on your specific digital footprint through space over time, okay? So diagnosis, history and physical is important, and this is basically everything health-wise that's happened to you in your life. We do H&Ps on people when they come into the office. We ask them about their health history. Did you have chickenpox when you were a child? Okay, that's part of the history. What surgeries have you had? And then we do a physical assessment, head to toe. Get out the stethoscope, look in the eyes, look in the ears, do movement, all of that. The trajectory and what you're seeing in the patient is important to understand. So is the patient on the decline? Are they holding steady? Even if they have 3 chronic conditions, congestive heart failure, atrial fibrillation, and diabetes. But are they holding steady? Or are they improving? That's what we'd like to see. Better quality of life. Current vital signs become important to understand. Symptoms that involve specific body systems, medication, what they're on, the type and dose, and when that changes is important to understand when we're thinking about raw sensor data for smart homes. Because I think that we can see some of those changes actually in the raw sensor data, or at least the results of that, which goes back to that sort of circular programmatic evaluation. If we intervene, can we see whether we intervened appropriately or not? And then current function, what's our current functional status? And then routine and associated changes from daily patterns. When you wake up, when you go to bed, when you eat, how many times the bathroom do you use at night? So I'm going to give you some examples to try to really pull in the clinical piece of this for you. And these are based on participants that I'm monitoring right now. We have SHIBs deployed to their home, as well as a Honeywell Genesis Touch telehealth system. So it's a fully regulated medical device approved by the FDA. It's used in a lot of telehealth programs across the nation. Multi-Care in the Tacoma, Seattle area has thousands of them deployed. They're a HIPAA compliant technology and platform. And so I deploy these to my participants, and I can video conference with them once a week. I get direct reports to my computer of their oxygen saturation, their heart rate, their weight, their blood pressure, okay? So this particular gentleman has Parkinson's, and his chief complaint is right hip and leg pain. He has dry mouth and poor sleep. His diagnosis, he has 3 of them: Parkinson's, Sjogren's, and hyperlipidemia. Okay, I'm pretty sure you can figure out what hyperlipidemia is. What is that? See, now if you ask me how a server works, I'll be doing the same thing. But hyperlipidemia, I can even say the word really easily. Yes, high cholesterol, but that's actually hypercholesteremia. Hyperlipidemia is high lipids or high fats in the system, okay? So he has high fats in his system, which means when you draw his blood, it actually, if it's really bad, can look a little thicker and can look more whitish than reddish than what you would expect. I probably don't have much time, but I have a really cool story from the ER around that, where I literally drew sludge out of a gentleman who was having a full heart attack, and we're like, now we know why. Because we were doing the blood draw to run his cardiac enzymes to see if he's in an active heart attack or not. We were literally drawing chunks of fat out of his blood. So if that doesn't scare you into eating healthy, I don't know what would. Sjogren's is just an autoimmune disorder that the primary symptom of it is dry mouth and dry eyes. This gentleman actually has a really dry mouth, and we can see his suffering from the dry mouth in the data. Severe dry mouth. I don't know if you've ever had a really dry mouth for even a single day, but this gentleman has severe dry mouth to where the tongue is actually white a lot of the time. And it's quite uncomfortable for him, and we can actually really see that in the data. You can read his history and physical. He has some previous broken bones. He has torticollis. Torticollis is when your neck is like this. I don't know if you've seen people who permanently have their neck in this position, but this gentleman does. And it's probably in part his Parkinson's. He walks pretty good, but with a walker. He is on the downward trajectory. His vital signs, his last blood pressure was 92/40. Is that normal? No, see, even like a non-clinical person would know that that's probably a little bit low. Like textbook perfect is 120/80, but 92/40 is a little bit low. We call that hypotension. Otherwise, he's within normal limits, but this blood pressure could actually cause somebody to faint. And yet other people can maintain at that blood pressure really well. So it just depends on whether there's a change in him. So we're talking about changes in health states. He has symptoms of lower leg weakness and swelling or edema in the lower legs. He's on medication for his Parkinson's. So this is carbidopa. Levodopa is, we give, levodopa is the dopamine. You probably have heard that there's dopamine associated with Parkinson's. We like to boost that in the brain. So we give this medication that basically allows it to be utilized in the brain better. And the carbidopa, when we do that, we actually make people very nauseated. So we have to put the carbidopa with it because it tells the brain not to turn on in the brainstem the nausea and vomiting factor, so that they can take the medicine and actually tolerate it. Because it doesn't do any good if you swallow the pill and then puke it back up. Pretty practical. His current function is he's independent, and he drinks water frequently because of the dry mouth, and he often sleeps in his recliner chair. So when we talk about measures, how much time do I have? 40 minutes? Oh, okay, we're doing good. When we talk about measures, I said earlier, like I organize the medical information, and then I go out and I look in the literature at measures. Measures are what type of sensor are you using, and which type can detect which kind of movement, and how are you measuring that or associating that with a particular health condition. Are you using walking speed to measure someone's change in pneumonia? Okay, if the pneumonia is getting worse, they're short of breath when they're walking, they're probably going to slow down because of the oxygen demand on the heart. Okay, so that's what we talk about when there's a measure. Measures that I see in my research when I'm looking at the data are listed here. If it has an L beside it, it means that it's out in the literature. Like somebody has published saying that we're going to use sleep to measure something related to somebody's health, okay? If it has a C beside it, it basically means that I'm using my clinical judgment to say that I think this is a reasonable way to measure this, but nobody's written about it in the literature yet. So you can see all the C's there. So I could probably work till I'm 80, which would be really great, because you know there's not going to be retirement for me, let alone y'all. And if there's this asterisk by it here, that means that I am using those specific things to look at Parkinson's, okay? So we know sleep is an issue with Parkinson's, and it's certainly out there in the literature. But sleep location is also important with Parkinson's. People change their sleep location based on how they're feeling with Parkinson's and how their movement is. Sometimes they just can't get out of the recliner chair to go to the bed at night. Unless they take their carbidopa-levodopa, a short-acting one, so that they can actually stand up to get to their bed, because that sometimes they get frozen with it, okay? We can look at walking speed in relation to Parkinson's. Well, that makes sense because Parkinson's is a movement disorder. And so how we walk and the speed of that will change. Repeated behaviors and bathroom use. Those are both, I use those both for Parkinson's. And the reason that I use repeated behaviors for Parkinson's, who knows anything about Parkinson's or has done any reading about Parkinson's? Can you think of why repeated behaviors, if we look at somebody repeating a certain behavior, how that would tell us anything about Parkinson's? Exactly. Sometimes you just have to get going. And so you have a pattern that involves you getting going, especially in the morning or after you wake up from a nap. Exactly. Yeah.
A lot of times, like my grandfather has Parkinson's.
Uh-huh.
A lot of it has to do with like memory. So if they're doing a task, they're not remembering that doing it.
Absolutely. Cognitive impairment is part of the clinical profile of Parkinson's. So you might repeat behaviors as you enter cognitive decline. That's absolutely part of it. There's also things that you do repeatedly with Parkinson's, like if you're into the moderate or even just before the moderate stage of Parkinson's, you will be taking medications on a regular basis. And if you're doing the short-acting carbidopa-levodopa to keep your body moving, you'll be taking that every 2 hours, 24/7. So that's a repeated behavior that we can pick up. So if we know that carbidopa-levodopa every 2 hours helps patients, and we have somebody missing those doses, that's clinically relevant, okay? We can pick that up in the sensor data. Also, activities of daily living, I think that's a pretty common one. Social isolation. If you had a movement disorder and it was getting harder to function and you weren't thinking as well, would you be as social as you used to be? Probably not. So social isolation becomes important to understand from looking at the trajectory. If you're on the decline, if you're on the even, if you're on the incline, getting better. It also becomes important for quality of life and understanding what we need to do to intervene to improve quality of life for these folks. I'll talk a little bit more about sensor activation combinations and bookends